Welcome to the first podcast in a series of 3 highlighting UV technology as an adjunct to your infection prevention practices. This podcast very much for the supply chain professional who is evaluating this emerging technology. There's a lot out there, but how do you take a value-based approach to considering these technologies? What do you need to know? And why is this important to supply chain? Pathogen transmission is an operational, financial, and sustainability risk, and there are hidden costs associated with transmission events. And UV as an adjunct technology can help you reduce those transmission events. But when you're looking at the tech and you're trying to figure out what might be the best option for your organization, there's a lot of important information to consider. And there is some FDA regulation that has recently come out, and that standardization can help you make the right choice for your organization. And so we're going to dive into that in our conversation today with Steve Egbert, Senior Vice President at XENDELLA, and Dr. Sarah Simmons, Science Director at Xenex. So stay with us. We'll be right back with Steve and Sarah after a short break. Welcome to the Power Supply Podcast. Today's episode is actually the first and only CEC approved podcast on UV for supply chain professionals. I've got a couple of great guests joining me today. Steve Egbert, Senior Vice President at XENDELLA, and Dr. Sarah Simmons, Science Director at Xenex. And I want to welcome you both to the podcast. And maybe Steve, we'll start with you and have you talk a little bit about yourself and your background in the industry before we jump in.
Yeah, thanks, Justin. I appreciate that. Hello, everybody. My name's Steve Egbert. As Justin said, I've been in the healthcare industry for around 25 years, a little more or less, but have had a great passion about, safe spaces and healthcare spaces. And most recently in the last 4 years, Justin, have focused a lot on the senior living environment as well. So healthcare and senior living is where I've been in that space, and, leading teams that are responsible for cleaning and disinfecting. That's been my role for the last 20 years.
And Dr. Simmons, if you could do the same, introduce yourself and your background and tell us a little bit more about your role.
Thank you so much, everyone. My name is Dr. Sarah Simmons. I'm the Senior Science Director here at Xenex Disinfection Services. We are a UV vendor within the space, but my position here on the podcast is going to be to talk about the clinical relevance of these products generally. I am an infection preventionist by training, and I actually worked in the hospital system for 5 years before transitioning to industry about 15 years ago.
I love it when we talk with people who, not only bring solutions to the table, but have that experience. I think a lot of people like to say on the other side of the table. And it's a common phrase, at least in supply chain. The other thing that I love about supply chain is that individuals that are working in these departments get to learn a lot about all the other departments in the hospital. Not that many departments get to understand, or many functions in the hospital get to understand comprehensively what's going on inside the entire, healthcare environment. And it also requires many people working in the roles to understand a lot about a little, or a little about a lot. It really kind of depends on their role. And environmental services is one of those that also has interesting reporting structures. I think it moves around sometimes in terms of like where they report within an organization. And, I thought we might start today with just, talking about maybe some of the realities around manual cleaning that's happening. I mean, we're obviously here to talk about infection prevention and UV technology, but I feel like EVS teams, depending on, how they're staffed, sometimes they can be outsourced. Sometimes, they're employed directly by the hospital. But there's a little bit of a challenge there because there's lots of chemicals. Either one of you can kind of kick this off. Maybe Steve, you start with maybe what are some common, challenges around the manual efforts and really creating sort of a standard of care.
Yeah, thanks, Justin. The industry's changed a lot over the last 20 years. I remember when I first came in, there were a couple of chemicals, We didn't have a lot of, different organisms that we were up against and fighting, and the transmission of them didn't seem to be on fire like today. You have, a patient or a resident that gets, C. diff, and next thing you know, the entire, everywhere, it just spreads so quickly. And healthcare workers, as well as, our environmental services workers are challenged with that. So over the years now, not only are environmental services leaders, responsible for training and making sure that we're cleaning, but now they have to wear the other hat, where they're also part of a chemist, because there's so many different chemicals, and, in supply chain, they know that very well, because, people are coming into their organization saying, hey, I have this great chemical, well, is it FDA approved? Is this, that, and the other thing? There's so many different things. So it's changed a lot, the landscape of it, and understanding, what chemicals you have to use for cleaning. The other thing we're always faced with too, in the manual sense, talking about manual cleaning, Justin, is staffing, right? Staffing is a challenge for not only us, nursing, everybody else as well, but in those spaces, when you don't have the proper staff, where do you pull to make sure that, rooms are properly cleaned and things of that nature. So those are some of the challenges that we come up with, but there's so many different chemicals now. You have a certain chemical to clean, C. diff, you have a certain chemical to clean something that is, TB related. And the great thing about, UV, and I've been using it, I didn't mention this in the beginning, for about 12 years now. And, it's a supplemental level of cleaning, but it certainly helps us be more effective and making sure that we're actually doing the cleaning, because manual cleaning, sometimes staff are rushed. We're trying to turn over rooms quickly to get patients out of the ED, to let other patients in. There's just so many different factors. And when you're managing that, it makes it challenging. And then when you have your 2 or 3 call-offs, where are you robbing Peter to pay Paul?
So I'd like to chime in real quick on something Steve said. He mentioned different chemistries for different organisms. And in a perfect world where the bacteria stay in one place, right, where the C. diff don't leave my C. diff patient's room, that's a great system. But we know that bacteria move around on the hands of healthcare workers. They move around on portable equipment. So when we're limiting chemistries to certain organisms, great for the room the patient's in. But if we aren't doing treatment that covers everything throughout the entire hospital, we can be leaving things behind. And that's one of the reasons why UV technology can be so helpful to hospitals.
Yeah, and just the impact financially of hospital-acquired infections has really come to the forefront. I mean, we weren't under that model when I was still working as a nurse, but I remember C. diff. And I remember the concerns around, potentially spreading that even on your scrubs, your own clothing as a care provider. Right. It really is a kind of a daunting effort. And you talked about the staff and the challenges of maintaining appropriate staff levels. Everything you just said, both of you just said, leads me to talk about training. And how do you make sure that the staff that you are putting in those positions would have the training manually to be able to cover all that, even if you had an effective program that was addressing the potential spread? How do they know which chemicals to use? Are they always using the right ones? And how to use them? Like dwell time is a big one. And when you're talking about like surface disinfection, right? So that's another one that, they may think wipe and dry and they're all good. And really they didn't kill anything because the dwell time wasn't long enough.
No, that's a good point, Justin. I've actually did some testing on my own with my staff in the healthcare setting. When you have for instance, back 10 years ago, disinfectants, a quaternary disinfectant had usually a dwell time of around 10 minutes. Now, honestly, also having experience with managing the engineering side of it, the HVAC, in a healthcare setting, you have your circulation is about as good as it gets in any environment, the filtration and everything for the air. So you have air circulation that's happening. And I've sat there with a time clock and literally saturated a mattress in a patient room with disinfectant, or had one of my staff members and hit the time clock. And literally within 5 to 6 minutes, all these surfaces were dry. Within 5 minutes, most of the hard surfaces, they were dry within a minute to two. So like you said, Justin, to your point, we're not getting the effective dwell time. Are we really even effectively, killing any of these germs or whatever that are in that room? So that's where I was like, you know what, there has to be something better and more effective than just like a bleach. And then again, you start using bleach and then you have all kinds of other issues that you have, with your staff and safety. So that's when, UV was introduced to me and I was like, wow, this is great. How this would be a significant advance for us and how we can really clean and keep people safe. And one of the, a little quick story there, the client that I was working for had several surgical site infections happen. So there was a lot of financial impact to the organization. And so we were trying to come up with solutions and answers in the surgical suites to reduce that. And manual cleaning, again, flooding floors and doing that thing, the standards that we do and doing the terminal cleans just weren't effective enough. And that's when I was introduced to UV and we started doing that. And we've seen just a drastic decline in surgical site infections over the years and went from like a 13 in year, just say 2010 to, 7 in year 2011 to 3 in 2012. And literally within 3 years, they were down to 0, infections, surgical site infections. And again, you have a lot of quick turnover. People are going in. Your surgeons want to get their patients in and out because they have a whole list of them. So there's so many things, and having UV and just doing that at the end of the night on all the surgical suites, we saw a major reduction. But again, it really helps because all we have to do is put the robot in there. I mean, we're still cleaning with disinfectant. You start the robot, let it do its thing, and then the staff move on and do other tasks, and it ends up being very operational and working out. And they don't have to remember all the different chemicals that they're supposed to be using.
And from a training perspective with the UV devices, the way I like to train users for these systems is to have them stand where the device is going to be in the room and look around. And I tell them, if it can't be seen, it can't be clean. These UV systems are line of sight technology. If the light isn't getting to them, that surface isn't going to get treated. This is why we have multiple positions within rooms for these systems to make sure we're getting all those different surfaces. And for supply chain managers, I think it's the utilization of the system isn't really their focus, but making sure that their users are getting feedback on appropriate utilization. Is the system you're considering going to let your staff know how the room is supposed to be treated? Are they going to know if they missed a spot? And is there back-end reporting for both EVS and IP to see, is our device doing what we wanted it to do?
What is the science telling us? I mean, I'm sure there's a lot of, studies and evidence that have been put behind if we had appropriate staffing of EVS, even if we were overstaffed and we just put more and more extra time towards the problem. Does that get us, great effectiveness? Does time equal value, I guess, in this scenario? Or are there limitations that UV is addressing?
So that is a great question. There was a fantastic study done a few years back where they evaluated, I believe they were using the UV fluorescent dyes in a room, and they were evaluating, you have 20 minutes, go clean this room quick. We're going to put a new patient in it. And then they had the staff take as long as you think you need to do this room right. And there was not a statistically significant difference between the surfaces that were missed in each group. The take all the time you want group did better, but not to a level that we would see that surface transmission risk reduced. And then as far as like research on UV products in general, I would say that the research is important, but what's more important is actually the FDA's regulation of this space, which we can absolutely talk about more because I think that's really important to supply chain managers. But the FDA did step into this space. They have said that devices that are selling into the healthcare arena need to meet their regulatory standards. So that's sort of the hurdle to clear. Not necessarily, are there RCTs out there? Do we have case control studies? It's, do you meet the FDA's benchmark?
Here's another thing that we talk about a lot too, is the bacteria are getting stronger and they're, multi-resistant. I remember when I first was getting into nursing. I think it was my senior year in nursing school. There was a 13-year-old girl that I worked in one of my clinical preceptor rotations, and she got MRSA after a spinal fusion, and she did actually wind up passing away. But I remember MRSA was like incredibly challenging at the time, and I know that it still is. But there are even stronger, multi-resistant bacteria out there now, and it just keeps getting worse. Why is this? Could somebody kind of paint the picture for us about why this is getting more and more challenging to take care of?
So there are a lot of things that are causing the evolution of these organisms, both within the hospital environment, but also within the world around us. There are changes to the way we manage antibiotics in farming and ranching. There are changes to the temperature of the environments around us that can encourage bacterial propagation just in our front yards, right? In our showers at home. There's a world that's warmer, and that lets the bacteria hang out with each other more. And that hanging out with each other also means that they can share genes. A lot of bacteria have what we call plasmid-mediated resistance, which is a big word, but it means the bacteria have resistance on pieces of DNA that they can swap back and forth like Pokemon cards, and they want to catch them all, right? And so we can get bacteria that have multi-drug resistance or pan resistance. That means there's nothing we have left that's going to treat these patients. And these organisms are also really, really good at hanging out on surfaces in hospitals. So we're getting more of them coming into the facilities. They're becoming resistant to the disinfectants that we use, quats, bleaches, and they're really good at hanging out for a long time. Now, what's nice is that for UV devices, the antimicrobial resistance of the organism has nothing to do with the UV resistance of that organism. So you can have a standard E. coli and you can have a pan-resistant E. coli. UV is going to kill them just the same. So that's another nice leg up for UV systems in the hospitals.
That's a really important factor in sort of how we're going to handle this, because I think people were just relying on antibiotics and, we'll just keep doing that. But there is kind of an end of the road for antibiotics. It's not going to work at some point. They're going to get resistant. And I know that the investment in creating new antibiotics, because their effective life, once you've developed it, the ROI is getting diminished so significantly that there's less money flowing into that methodology for treating, patient infections as the bacteria has become more resistant. So I'm really glad that you pointed that out. And, we're going to talk about this a little bit. Maybe we get to maybe a little bit more of the operational indications for supply chain after, because I kind of want to segue from what you're talking about there and really just talk about the fact that we're not talking about replacing manual cleaning. Like, this is adjunctive, right? So could somebody talk about sort of the role of adjunct technologies like UV in sort of like helping us tackle what is becoming an increasing challenge for preventing infection?
Really, Justin, the key is, and again, spending a lot of time working in testing different types of chemicals, different types of UV robots, because there are different robots that are UV, right? And I've tested them both. There's robots that have the ultraviolet light that's created by mercury, and then which takes a lot longer cycle time to be able to disinfect a room. Then there's the xenon type of gas that is used for the other UV. Again, both UVC they're creating, but making that operational really, again, and I worked in an environment where, have heavy union activity, and, the union at the beginning, just a little story of mine, they were concerned about replacing people, but truly it wasn't replacing. It was adding that additional level of the supplemental cleaning, as you talked about, to make sure that our spaces were safe and that we were helping the hospitals reduce, and the ROI on it was reducing any, readmission rates, in certain places. So they're not bringing in any replacement factors, But what they are doing is they're becoming a part of the team. And what I love the most about being in the operations is that the staff feel like they're a part of the team. They feel like, hey, if I did miss anything, then the robot's going to get it. Using the robots and making them operational is part of what the managers have to do, and it's part of the training process. But it is actually attainable, and you're able to do it, and you're not really adding any other work. I did a study for 3 years using robots in an environment, in a inner city environment. And, we were, talking with supply chain, talking with the infection control, talking with nursing, turnover rates. And so we tracked that, and seeing if there was any additional time that was added into turning over the rooms versus what they were doing manually, and adding in the supplemental. And if you make it operational and you work it the right way, it actually reduces some time. And that's what the Xenon UV really helped, because their cycles were like 5 minutes. And so putting those in a room, we could position them while the worker was in another area, so they're not directly in the same space, and be able to make it operational. And again, our team members felt like strongly that, this robot was a part of the team, and it really was. And they felt safer working in these environments, because again, we're in a diverse community of people that come in off the streets, that some people are homeless and they come in, and some people are coming from other countries and some places. And again, we don't know what that is. So as workers in that space and trying to clean that, having this additional level made our team feel much stronger about their safety working within the environment as well. I even had nurses say the same thing to me, Justin, and you're being a nurse. They're just like, oh my gosh, Steve, it just feels so much cleaner, that you guys have this robot here. And we love that, because we work in this space, every day, and long hours and double shifts and things of that nature.
It's pretty hard to know what you might be exposed to in a lot of cases, because it's hidden, unless it's really obvious, like gross blood or bioburden that's really right there in front of you that you can see is dirty. But there's a lot that can be transmitted without you even realizing it's there. And I think, to your point, that peace of mind that you're not going to be exposed to something in a room that you're coming into that may not have been appropriately cleaned prior to you. I think that peace of mind is huge. And when you talk about the workforce challenges, that's a big piece of it, is knowing that they're in a safe environment that they're doing this work in. I just think that's really, really critical. I do want to get in, obviously evaluating these technologies is a big supply chain concern, but, you mentioned I'm a nurse. A lot of times I think people look at this as kind of more of a clinical sort of concern, but it really is more than just the clinician's concern, right? It's not just a clinical issue to be dealt with. Can you maybe expand on that? And then we can dive into things that maybe supply chain should be aware of as they're evaluating these technologies, because there's a lot of them out there now, and there's a lot of conversation. I'm sure the FDA regulating that became it was actually a good thing, not only for the regulation, but for the awareness, because once the FDA is regulating, it's like, wait, it almost legitimizes what many people already knew about how effective the technology can be in the studies that were coming out. But maybe, Steve, you start with this one. Why is it not just a clinical issue?
Yeah, because again, like you said, we have, many different members within the staffing of a hospital or a healthcare setting. You have food service workers that go in and out of these rooms where the patients are. You have the housekeepers. You have caseworkers that go in and out of these rooms. And knowing that you have the ability to, supplement that manual cleaning, which again, there's been many tests that have been done over the years, just proven that their surfaces, do not get disinfected with manual cleaning, even having our best housekeepers doing that. But yeah, having multiple people that go in and out of these rooms every single day, it is more than just a clinical issue, because now you're worried about, am I taking anything home to my family? Right? And I think you made a point, which was a really good point. I mean, we always train our staff on universal precautions, right? Gowning up and doing all the things that they're supposed to be doing, going into cleaning the isolation room. However, again, being rushed and doing these different things, and food service workers might get, coming in and just delivering a tray, setting it up and going out. Am I bringing these things home? Am I bringing these to my community? The germs that you talked about that are not seen. And so that's where I think, we really, it's more than just a clinical issue. It becomes more of like a community issue is the way I look at it. Knowing that we had robots and we were cleaning and disinfecting with them, and I could take a robot into a room and clean a room, and knowing that, I felt more safe than anybody else going home. I mean, we would all bring our keys, our cell phones, all that. I'd have all the staff. We'd put them in a room. We would run a 5-minute cycle with the robot, flip the phones over, run another one. And now we're taking our cell phones, which are probably the most biggest carrier of germs that there is.
Your hands are the number one transmitter, right? And so, yeah, absolutely. The phone is, I always wonder about that because I bet most people don't clean their phones.
Yeah, so it was fun. The staff enjoyed it. They enjoyed it doing it. I had staff from other departments coming over because I'd be like, we would do this at like 2:45 every day. Like, come to this room. We're going to, run the robot and everybody's going to disinfect their cell phones. So I had nurses coming down. I mean, it became sort of a fun thing that we did every day. But again, it was more about helping everybody within the community going home and, not taking things home with you.
All right, let's help the supply chain audience listening to this podcast, some good tips for what they should be looking for and focusing on if they are sourcing UV technology as an adjunct technology to the manual cleaning efforts that are going on. What should they be looking for?
I'll start because I think one of the biggest things, and again, we learned this in COVID, Justin, we had UV things coming out of the woodwork. People were making stuff in their garage with a mercury bulb and calling it a UV device. I think the biggest thing is the support from an operational standpoint. No, I'm just talking from an operational standpoint. Having a UV vendor that is going to be able to support and not just say, okay, I'm stopping in every month, or I can give you these reports remotely, but making sure that your machines are running effectively. And they can check that. They have ways to do that, and making it operational so that there's safety measures. That's another big key thing, right? My supply chain VP was calling me almost daily, in COVID saying, Steve, I have another company here with a UV, do you have time to come meet with them with me? And it's like, but again, a lot of them didn't provide any of that additional support, the safety training, things of that nature. And I think that's really important operationally.
And then from a clinical perspective, as I mentioned, FDA now regulates this space. In 2023, the category of whole room microbial reduction device was created. And this is for any UV system that is designed to be used in a room to reduce the microbial burden on those surfaces. In that time period, 2 devices have received clearance. And I think that speaks to the challenge that devices need to clear in order to reach this regulatory status. And it's not just microbial efficacy, right? That's certainly a major component. We need to demonstrate this 99% reduction in organisms on surfaces with the cycle times we're claiming. But we also need to meet electrical safety standards. We need to meet fire safety standards. We need to meet cybersecurity safety standards. And these are all things that in the past, a supply chain manager would need to evaluate independently for all of these systems. But under the FDA regulatory rubric, that's all done for you. If the system has that FDA authorization, all those boxes have been checked.
Wow. So it can actually speed up the sourcing process. Because there's now a recognized standard in the industry, you can whittle down the technologies that you're going to evaluate in your procurement process and some of the work that you might be doing from one hospital to another to figure out, what your standard is or what you're requiring from the technology. I thought the electrical piece and the cybersecurity piece was like really something I would not have thought of in this particular technology, would not have occurred to me. But the fact that that's being, considered to be approved really does help make the technology more adoptable, because I think some of the times what happens is you get 20 different technologies that come in a sourcing event. And it's sort of like, then you're trying to sift through that. And when you don't have standards or regulation, it's really hard to whittle that down. And of course, you're going to use this technology in most every department in the hospital. So depending on what the sales environment's like, you could have salespeople with different influencers from different departments all championing different technologies. That's complicated for supply chain. What I love about this is it really does help them get down to a couple of technologies when they're evaluating that. That's fantastic.
Yeah. And so, for example, the VAs have made the decision that for all of their hospitals, all of their facilities looking to purchase UV technology, their supply chain will only authorize purchases of FDA-approved devices. So that's certainly a choice facilities can make. There are 2 systems out there to pick from.
That's fantastic. All right, so we're getting close to the end here, but I think another important consideration for supply chain is just, which technologies, can you get the most value out of? I mean, we're always trying to figure out, can we do more with less? And so, Steve, would love your thoughts on any considerations in that area for the supply chain folks listening.
Yeah, no, thank you, Justin. It's really important. And again, we've talked about a little bit in the podcast. There's really 2 choices that you have. You have the choices of using UV technology that's created through xenon gas versus those UV technologies that are created by mercury bulbs. And again, I've used them both in the space. And from a supply chain perspective, when you're looking at the value that you get, for me operationally, for the organization, I can do double the amount of rooms disinfecting with a robot that has UV created by the xenon gas versus the mercury. It's going to show the value that you can get because of the volume that you can do with one versus the other.
Steve, I think very important considerations there around the technology, but it is interesting. It's like we're whittling down a very large space, but with FDA and the certain types of UV technology and the gas that's used with the technology that you're sourcing, it's starting to make decisions a lot easier, I think. And again, I think there's this whole conversation happening in supply chain these days around speed to value. So like one of the things that hurts healthcare organizations long term is sort of being indecisive and not making some decisions. And so I think we've really helped whittle that down for people, and speed to value can be obtained. But there's also speed to value in just how quickly can you get coverage in your healthcare organization for this technology on all of your surfaces. But I think at the end of the day, this conversation around infection prevention, transmission control is really about creating something that's sustainable in your healthcare organization, because there are a lot of costs that are going to hit you if you don't have a handle on infection prevention, and it will really hurt. And these are very, I'd say, difficult fiscal times in healthcare. The budgets are never been tighter. And so when you think about speed to value too, it's like every purchasing decision is scrutinized. Is this going to bring a return on our investment? And so there's a lot of considerations, and some can be measured very easily and some cannot be measured very easily. And so that's where we need the studies and the white papers to help us out with that. But, Sarah, I wondered, do you have anything to add on, just kind of how you look at infection prevention as a real key driver to, healthcare facilities and them being, viable for the long term?
Sure. So the marketed claims for these UV devices are that we can get a 99% reduction in the bacteria that are left on your surfaces. But the end game for why that matters is because if the bacteria aren't there, they don't transmit off of that surface to another patient. And the result of those missed transmission events is that next patient can get out of the hospital sooner. We can free up a bed for a new patient to come in. Patients are not going to be receiving unnecessary doses of antibiotics, right? There are ways we can quantify these impacts for hospitals. And the infection prevention teams are going to be knowledgeable in how to do that sort of economic math for the impacts within their particular healthcare systems.
Well, this has been an excellent discussion. We're going to wrap up here. I'm going to get some final thoughts from each of you. But before we do that, I do want to just thank you both for sharing your insights with our audience today and really helping supply chain understand, how they can be a strategic partner in reducing risk and really supporting sustainable care delivery as it relates to infection prevention. And, a department that is typically, on the lower scale of, budget, which is EVS. I mean, they're a big budget in terms of their size, but, they're also a support department. They're not necessarily seen as a revenue generator. And so when you think about the amount of expense that's spent per head that's in that department, I think that rate is oftentimes pretty low. And so I think adjunct technologies like UV can be really, really exceptional in augmenting that and having a great impact on the healthcare organization. So, Dr. Simmons, let's start with you for final thoughts, and then we'll go to Steve.
Sure. So I think, as you've heard me say many times now, FDA authorization has been key within this space when supply chain is making a decision list for UV technologies. That should be number one on the list, in my opinion. And then I think making sure that the system is going to be supported, as Steve mentioned. It's not just, training the staff how to use the device. It's clinical support as well. The way these devices can be used within the hospital is very flexible. The way we would address, MRSA in a NICU is completely different than how we would address C. difficile in like a med-surg or a rehab. And having the clinical expertise with your UV vendor to make those changes on the fly is really helpful for your infection prevention team and your EVS team so that they don't have to be the full expert in everything. You have someone you can call.
Steve, thanks again as well for joining us. What would you like to add before we wrap up?
Yeah, no, I appreciate it. And hopefully this is going to add value, in the space that we talk about with the different UVs. I've used them both. And I just want to say from an operational standpoint, they're very competitive in price. Don't let that deter the supply chain folks that are out there. Cause it like you said, it's for a non-revenue generating department, but I've seen it and I've used it, like I said, for 12 years. And I know that it does make a significant impact in the cleanliness of your facility, especially if it's used and it's operationalized. I personally have experienced it, and it's a great feeling to know that, because every day you go home, you go, wow, I know that I made that place cleaner for the patients and for the people that are working there. So don't let that, the price of these, it's really, really important if you're going to drive things, outcomes like you're talking about, Justin, with readmission rates and surgical site infections and hospital-acquired infections, all those things. Adding that supplemental level of UV, the robots, part of your team, is invaluable, in my opinion, from an operational standpoint.
Well, thank you both so much for your time and your insights today. And for those of you listening, this is the first and only CEC approved podcast on UV technologies for supply chain professionals. That was Steve Egbert, Senior Vice President at XENDELLA, and Dr. Sarah Simmons, Science Director at Xenex. Great conversation today. I love that the FDA has leaned in on these technologies and helped bring some standardization and really assist healthcare organizations in evaluating, what does quality look like? What does impact look like? Steve and Sarah's insights today, really, really helpful. And this, as I said at the very beginning, is the first in a series of 3. So we have more conversations to come in this CEC approved podcast on UV. It's the very first of its type. 2 more episodes to come. Thanks for listening to this one. Stay tuned for the next episodes here on Power Supply.